Again, we have a beautiful city with all these things going for us. We've got the river, the ocean, I-95, I-10. We should be a very successful metropolis in every corner of our community. 875 square miles. Jacksonville is very spread out. There are parts of our community that do very well, and there are parts that do not do so well. So we need to focus more on the areas that are not doing well if we want an overall healthy county here in Duval. Health factors also play a role in our overall health ranking. We actually do pretty well. That's because we have excellent clinical care in Northeast Florida. We have UF Health, we have Baptist Health, we have Mayo Clinic. Our clinical care is pretty strong, and that's part of what goes into health factors. Let's take a look at those social drivers of health. 80% of what make up health is not related to what happens in the office, at the doctor's office, in your doctor-patient relationship. When you look at health outcomes, only 20% of that comes from the health care you receive from your doctor. The other 80% comes from your physical environment. Housing, transportation, air and water quality, income plays a huge role, and so does community safety and employment, education, and health education. All of those things are included. All of us, all of these things play a role in whether you are getting the appropriate level of health. This is why we talk about the social drivers of health. These are very important to the health and well-being of citizens here in Jacksonville. Getting more doctors or more healthcare providers and health organization is not the problem. We have to focus on the other 80% that affects our health and our well-being and here in Jacksonville. Let's break a couple of things down by zip code. Let's start with education. You're looking at the percentage of population with less than a high school diploma. In the green areas, a very small percentage has less than a high school diploma. The red areas represent 30% of the population with less than a high school diploma. North and west of the river, there are more health issues where there is lack of education. And now hold on to that. Then we look at the percentage of the population living in poverty. If you put this map on top of education, you see that the same areas with low education rates are those living in poverty. They correlate with each other. Let's look at income. Median income also coincides with poverty and is in the same areas where there is issues with low education levels. Let's look at percent minorities per health zone. When we look at the percent of minorities by health zone, the same thing is revealed again, where we see our minority population having the same issues north of the river or west of the river are having the same challenges, whether it's education, income, or living in poverty in this beautiful 875 square mile city. And then life expectancy. The health zones are broken down based on life expectancy. So in Health Zone 1, you can see the life expectancy is 71 years old. If you cross the river and go down San Jose, it goes up to 80, a 9-year life expectancy increase. And I believe that this here lately, that gap has increased. That's crazy. Something's not right about that. It does not have anything to do with the community, but it has everything to do with where resources have been distributed for generations. And you can clearly see that in the numbers. Life expectancy from birth is a summary measures of mortality that is used to measure geographic inequalities. Health Zone 1 has a 4 to 9 years shorter lifespan than all other health zones. Health Zone 2 and 3 and 6 have the longest lifespan overall. We have food deserts. where we have issues with income, education, and poverty. This is where there is no access to grocery stores where people can get fresh foods. However, there are plenty of fast food restaurants and minute markets that you can get something really fast, any quick. There's one on every corner. You can't miss them. How do we assess a community? We assess the community by how well we treat our children. Our children in poverty has consistently been higher than the rest of the state and even the national average. We had a period of time where we were doing okay, but as you can see, we didn't stay there. Our infant mortality rates also correlate with poverty, education, food deserts, etc. They're parts of the community that do so, so much better than we do in other areas. So if you take a look at this graph, it shows infant mortality rates from 2015 to 2021. We're looking at live births per thousand and babies not surviving until their first birthday. That's how we measure infant mortality. It correlates with minority status, poverty status, income status, and education status, and prenatal care. So in the green, we're talking about 18 babies per thousand not making it to their first year of life. In the red, we're talking about anywhere between 0 and 5 babies out of 1,000. You can see that we've had some improvements in infant mortality over the last few years. However, 12 out of 1,000 babies born in Duval County last year died before turning 1. This is regardless of their socioeconomic status. This is a communication gap. We are 3 to 4 times more likely to see African American babies die than Caucasian babies. We know where we need to focus. Some of our attention needs to focus in those particular areas. Our current infant mortality rate overall is 6.1 in Duval and 3.5 for Caucasian babies and 12.4 for our African American babies. When it comes to uninsured rates, with the onset of the Affordable Care Act, which really kicked off in 2014 after they got some of the kinks out, more people are getting insured. The uninsured rate has decreased, but we're still worse off than the rest of the state and the rest of the country. This graph shows how our lost years of life started to separate further from the rest of the country around 2015. Somewhere around 2012, our homicides were going down. Our homicide rates started to go down. Then that changed, and they continued to rise. So what happened? When we talk about calculating years of lost life, remember it's the number of years of life lost before the age of 75. When there's a homicide, who's dying? Maybe 20-year-old, 18-year-old, 25-year-olds. You just lost 50 years of life. When you see the violent crime and homicide rates increase like this, and we're continuing to lose young people in dramatic ways, dramatically increasing our years of lost life, it is directly tied to the health of our community. So again, 80% of what makes up health is not related to what happens in the office when you visit your doctor or the relationship that you have with him, no matter how good it is. When you look at health outcomes, only 20% of what comes from the health care you receive from your doctor, that's pretty low. The other 80% comes from your physical environment, housing, transportation, air, and water quality. Income plays a huge role. And because if you don't have the money, you're certainly not going to go to the doctor to get health care because more than likely you probably can't afford the majority of the copays. Community safety also is a problem. Employment, education, health education included. Health literacy is so critical because it's so important that people in our community understand what that means to take care of yourself, what it means to be healthy. All of that plays a role in whether you're getting the appropriate level of health. This is why we talk about the social drivers of health. Getting more doctors or more healthcare providers, it's not going to make a big difference. That's not our problem. We can focus on that other 80% that we mentioned. So, what can we do? How can we make an impact? This data is probably not new to any of you, and many of you on this call know what our challenges are with health and well-being. And hopefully, the majority of you have some idea of what some of those things are. So the question is, what are we going to do about it? What can we do about it? What are we doing about it? We can talk about things, but our mayor wants us to make an impact. She's very specific about that. Dr. Sunil Joshi, who serves as our chief medical officer, and I have been bringing like-minded people together who share the same vision. We're bringing organizations out of their silos and challenging them to work together. This is our job, a big part of it. We're asking the community quarterback organizations to lead the charge. This is how we want to work together and move forward because it's important. We must look at the big picture. We have to look at the big picture. Collaborate, communicate, and support everything they do to improve the health and well-being of citizens here in Duval County. These are the areas that rose to the top with our community members as issues that we need to address right away. Access to primary care and dental care, maternal and child health, elder food insecurity, mental health and substance misuse, health insurance access, and the social drivers of health. So what are we doing? And I believe we're doing something pretty cool with this initiative. This initiative is designed to address access to health care, access to primary health care, a program called HealthLink Jacks, which many of you may have heard about, I hope you have, that provides every person who does not have health insurance with immediate access to a doctor and a care navigator 24/7. That connects a patient directly to a physician. All you have to do, or anyone has to do, is call 935 CARE, 925 CARE. There's a big financial impact for helping people stay out of the emergency room. Average cost of an emergency room visit is anywhere from $3,500 to $4,000 per visit. Every patient that calls is treated and connected to a medical home coordinated by Jack's Care Connect. It's a partnership we have with them, who works with every safety net clinic in our area, all of the free and federally qualified health clinics they're working with. Agape, Sulzbacher, Mass, Community Health Outreach, Volunteers in Medicine, Mission House, and other subspecialty cares such as We Care Jacks, who focuses on specialty care. So if we're keeping these people out of the emergency room and providing them with a service and embedding them into this primary care network, not only are we immediately saving taxpayer dollars, but we're getting them into primary care so we can prevent chronic health conditions. If they're seeing a doctor, they're not waiting until they get sick to see a doctor. They have a medical home, which is really important. So when they're not feeling well, they have a place to go. And it's so much easier for people to talk to a doctor sometimes, depending on where they live, where they are, and transportation can be an issue in terms of getting folks into a doctor's office. But if people who are uninsured can talk to a physician on their cell phone or on their computer, then we're going to have a healthier community because we're going to encourage them to use that resource and help them to understand that it's not difficult. And once they try it, they really do make good use of it. And I'll tell you a little bit more about that in just a second when I tell you what some of our most recent outcomes are for this effort. And these results are from when this program started, which was July 15, 2024 through March 31st of this year is what this data is from. We haven't gotten our data up to June yet, but it's due soon, so we should have that very soon. But just to give you an idea of how beneficial these initiatives have been working in our community. They've had, since that time, 2,298 encounters with people in our community calling in on telehealth. They've had social determinants of health navigation supported by people who are helping them to with health literacy and helping them find resources. You can see the numbers there. They've had more than 3,375 touch points. And when we say touch points, it might be someone calling in to say, how can I get my diabetes medicine? They may not need to talk to a doctor. It simply may be that the navigator would have to work with them in order to find a place where they can get their diabetes medicine without having to pay for it or guiding them directly to one of our safety net clinics. It's not always a doctor that's involved because it may not be necessary. Prescriptions are filled, 601 of those. Emergency department savings to this point has been $4,617,050. And so this is a pretty good savings we see as in terms of helping people have an option between going to the emergency room and talking to a doctor. This is some of the data that's come out. The number of people who've been diverted just from the UF Health emergency room has been about 165. How do we know that? We ask them which emergency room would they go to if they were to go to an emergency room. And that's about 17.3% of those diverted from using the emergency room for what they might see as an emergency. It might be a stubbed toe, it may be a sore throat, it may be an ear infection. This can be treated through telehealth and it saves everyone time, and it also prevents the emergency rooms from being clogged up with unnecessary care. If we can get folks to not use the emergency room as their primary care, which is our goal, we'll be able to save our taxpayers here in Jacksonville a lot. I think about the story, the young lady that I met who had asthma, and she had asthma and she lost her job. She was going to the emergency room once a month to get her medication, her inhaler. And once she learned about this program, she was really shocked and was able to save a whole lot of money. Her emergency room bill for going to the emergency room for 9 months was somewhere around $35,000 with the x-rays and all the other treatment that she was getting. Once she learned about HealthLink Jacks, she was able to then get her prescriptions by going through this pathway, and her medication was at no cost to her. And we want to be able to not just save our taxpayers' dollars. We want to save the community dollars and to simplify access to health care for everyone. So what are we doing for infant mortality? Well, infant mortality is one of the things that's really important. It's important that we establish a sustainable infrastructure to improve maternal health and outcomes. And these are things that came up when the transition committees were meeting and sharing with the mayor what we needed in our community, and the experts in this space shared this information with us. And so we added more community health workers. That's what rose to the top, so that they can provide home visits and provide resources, education for maternal health, pre pregnancy, during pregnancy, and post-pregnancy. Partners with current projects in the community we do to improve maternal infant survival. That is our goal, to keep women healthy so that they can produce healthy babies when they deliver. So here's what we did to help support that. We funded two community health workers, and these community health workers have been engaged since they began, which was a year ago, with 266 women in our community. They have referred them to home visitation programs. They've worked with them and their families. They've provided training on toxic stress, safe sleep, signs and symptoms of preterm labor. They Many of the women were pregnant. 81 of them were pregnant, and there were 30 non-pregnant and one male that participated in the training. They all received preconception health and safe sleep and infant mortality education. That's really important in order to have healthy babies, in order to have babies survive, and assisting women with making their appointments and helping them to make the decision not to wait until their third trimester, or if there are barriers that's preventing them from getting prenatal care, helping them to work through those barriers and helping them to work through those problems that they believe are bigger than they are, so that they can get the health care that they need pre-pregnancy to save all the babies. What else can we do? We learned that there was on the waiting list for Meals on Wheels, 2,700 seniors waiting to get a meal. And I want you to think about you and your family member if you had to put yourself on a waiting list to receive one healthy meal a day, because you feel like you need that to survive. I want you to think about what it takes for a senior to do that. And you've got to know that if they've put themselves on that list, they really believe that they need to have a healthy meal. Um, and it may not be because they are hungry, or they don't have the money to buy food. It may really just be because they don't trust themselves turning on and off their stove because of memory issues. They're not sure if they've made some mistakes before. They're not comfortable going to the grocery store. It's not always that they don't have the money to feed themselves, but they're not able to feed themselves for whatever the reason is, whatever the barriers are. And having Meals on Wheels not only provides them with a meal, but it also provides them with the opportunity for another person to lay their eyes on that senior and also the environment that they're living in. And if that person need additional resources, that person can we can make sure that they get those services that they need. So we partner with organizations that are dedicated to elder issues to coordinate and promote services that help older adults age independently with dignity in their homes and their community. The picture that you see on the screen is a picture of Mayor Deegan when she wanted to go on home delivery services. So we spent one day during the Christmas holidays for her to go out and serve meals to seniors in our city. Um, and that was pretty important to them and to her. And this young lady that you see in the center with the white um, we called them dusters when I was growing up, with the white duster on. She told the mayor all about her issues with her television. She was not able to watch TV. She said something was wrong with her television. And so immediately the mayor sent someone out to her house, this woman's house, the very next day to check out what was happening with her television. Can you imagine the Christmas holidays and you can't watch Christmas movies, or she couldn't watch anything? But those are the kind of things that sending these meals out to homes sometimes that they pick up. But the very next day, what we learned, it was her direct TV account. It had nothing to do with her television, but she didn't know that. And because she lived alone, she didn't have the help she needed for someone to help her with that. So she was thrilled to be able to have access to her television. Meals on Wheels is an excellent program that really does work to serve community members well. So, how does this look? What have we done? There was 2,800 people on the waiting list. So far, we've served 208,887 meals. There is 1,881 enrolled in the program, and we have cut the number down significantly from 2,800 to 956 on the waiting list. We would like to have that number be zero. But we have been able to decrease the waiting list by 66%. And this is some of the survey data that came out as we were surveying seniors. Nutritional needs improved by 92%, their quality of life by 88%, and their food insecurity improved by 94%. And this is from the seniors that were served. Let's take a look at mental health really quick. In the United States, 1 in 5 children and adults suffer with mental illness. And so we know the need is there, right? One of our goals is to increase awareness of 988, the 988 call center, and helping people with mental or behavioral health concerns. Um, and we have worked really hard with 988 and the United Way for folks with mental health issues and substance misuse. It's a big problem in our city. No matter the health zone you live in, it is an issue everywhere. Awareness and education, we do realize will reduce the stigma of mental health care. The City of Jacksonville funds to United Way crisis counselors to decrease the wait time for folks when they they call 988. It has decreased. The last outcome was the time decreased from 60 seconds to 22 seconds in terms of how quickly the phone is able to be answered. This may not necessarily seem like a big deal, but it's huge because if a 988 call for suicide is not answered here locally, that call rolls over to the national 988 operators. If and when that happens, that operator does not know our city. The national operator does not know the resources in our community. And their answer is to call 911. And when they call 911, that is more, it's risky when JSO goes out to see someone who is attempting suicide or feel like they are really having a serious mental health issues. We've seen the news. We know what happens. They're not equipped to do it the right way, but they are responsible to going out and checking out whatever the problem might be. If the calls can be answered here locally, we have people who are trained to to de-escalate those calls and to handle the potential suicide victim the way they should be handled. And they're excellent at de-escalating those calls. And I want to share with you just a little bit of data so far. 82% of the calls have been answered locally. And we're getting more calls, more and more calls. The more they're able to answer, the more calls we're getting. The calls have decreased by 12 seconds to 12.6 seconds. Now they're able to answer the phone instead of the 22 seconds that was mentioned earlier. 48% decrease in caller wait times. And that's really important because if a person has to hang on the phone for 10 minutes, 5 minutes sometimes, they will hang up because yet again, they begin to feel as if no one cares about them or their life. So it's important um, for the line phones to be answered pretty quickly. Health insurance. My goodness. We have worked really hard with enrolling community members into the Affordable Care Act insurance marketplace for insurance that they can afford. We have been very careful not to provide false information, but to enroll people in insurance that they can afford. We had phone banks in partnership with Channel 4 and offer and an opportunity to educate people and to get them enrolled in health insurance. One of the things the mayor says often is a confused mind says no. So our initial goal was to educate community members on what the Affordable Care Act insurance is and how it works, and to work with them on what they could afford. You hear the horror stories of people getting enrolled in insurance plans that they cannot afford. And so we wanted to make sure that we did not do that. Um, there is these are just numbers that compared to previous years enrollees and how many people we enrolled into healthcare insurance this particular year 2025. That number in Duval County, it was 24%. It's now increased to 63% here in Duval County, which is really important. Now I'm sorry, in 2024, it was a 49% increase. 2025 numbers were more like 64% increase in the number of people who were enrolled in insurance. What does that mean to us? We have people who are able to pay for their health care which saves our taxpayers a lot of money. And many of them were not enrolled because they didn't know what they didn't know. So how in the world does the big beautiful bill impact Jacksonville economically? So from Medicare cuts, Jacksonville will lose $37 million. For Medicare cuts, $3 million. Medicaid cuts, $37 million. From the Affordable Care Act changes, $68 million will be lost. And for SNAP benefits, there will be a $33 million loss. So altogether, approximately what we've been able to calculate since that bill passed, 141 plus $1 million, or 14% of the city of Jacksonville's annual budget is what will somehow need to be replaced in the loss of these dollars. So what can we do? We can address the social determinants of health, the social drivers of health to help people stay healthy. And we can use all of the tools that we have. We can reach out to community members. We can continue to work with our city council in order to develop pathways so that community members have access to healthy things, healthy food, healthy communities for walking and just healthy spaces altogether. Here are some more ways to perhaps find out what we're doing. Jacksonville.gov has a dashboard, and you can always click on that dashboard to learn, go to jacksonville.gov/dashboards to learn what the city is doing in all of our areas of priority in terms of what the mayor would like for us to work on. So, questions. Thank you very much, everyone, for your time. I really do understand how precious time is, and I appreciate you hanging around here with me. I went a little bit over time, but I want to thank you all for your time.
Good evening, Ms. Sherman. Thank you so much. A lot of rich data, good information. So thank you for laying this all out. This is Rob Thomas from Community Health Outreach. So I'm especially interested in your information regarding HealthLink Jacks. So those 375 touch points, and then the diversion for $4.6 million from the EDs. How did you get that number, that 4.6 million? That's what I'm really interested in.
Yeah, so calculating the cost, using the resources of the hospitals to share with us the cost of the average emergency room visit, consider for the average issue, and typically that involves either blood work, X-rays, other lab tests, and other lab
Hmm.
work, perhaps if necessary, a CAT scan. And so we retrieved that information from our emergency rooms, all of them, and that's how we calculated that number.
Very good. Thank you.
Mhm. Thank you. What other questions do we have? I'll turn it over to Natalie to facilitate it.
Yeah. Yeah, if anyone else in the audience has any questions, please feel free to unmute and ask. But until then, we do have a few guided questions, so I'm going to hand it off to Brittany to ask one of those.
Hello, my name is Brittany. I just wanted to ask, how is technology or innovation helping to make healthcare easier to reach out, like for everyone, and more accessible to those?
Very good question, Brittany. So I would say, telehealth, technology when it comes to telehealth has been really useful in a lot of ways. And we're excited to have that around, actually. And for us, that's for healthcare, that's about the biggest development in healthcare is not having to be transported to a doctor's office or a hospital, but be able to speak to someone on your computer or your cell phone and still get good healthcare.
Thank you.
Yeah, Madison, did you have a question you wanted to ask?
I wanted to know about how healthcare equity has improved these past few years and how you guys are working to implement more health policies that's focused on health equity.
Mm. We're still working on improving health equity in our community, and what I shared earlier, some of the ways we're helping to impact the health equity is by providing these other avenues or opportunities for service and care for people in our community. And we believe in meeting people where they are, no matter where they are, and not always expecting them to come to us, even when it comes to providing nutritious meals for members of our community. It's okay to have a food drive, but if you don't have a car, that's not equity, right? Because many times you're expected to drive through as opposed to pick up your bags and carry them down the street. And so creating ways to sort of even the playing field for people in our community is one way that we're working at providing equity in every uh, program or initiative that we have.
Yeah, thank you. So, unless there are any other audience questions, we'll f finish off. I have one final question. So, you mentioned a lot in your presentation about what we can do and a lot of the initiatives that are going on. Are you hopeful about the future in terms of access to healthcare?
Well, considering the new bill, I am concerned about the future of healthcare. Really am concerned because I'm not sure that the people in the average person really understands uh, how this bill is going to impact health and healthcare in our communities. So I'm hopeful. I'm always hopeful, but I am very concerned about the health outcomes that we're going to have in a few years. I do realize that the bill does not take place until go into to law until 2027. So we won't see it right away. We won't see the impact right away, but probably in about 4 years, you're going to see more people in the emergency room, more cost to citizens. You're going to see people who are uninsured not have places to go because, as we think about it, our safety net system, our clinics, our free and federally qualified health centers are going to be impacted. They're already facing budget cuts. So as they face these cuts, they're not going to be able to see as many people as they are currently seeing now, which means we're going to have sicker people in our communities, and we're not going to have the resources we need in order to keep them healthy or to get them healthy again. And so consequently, I mean, bottom line, there are a lot of people who are going to lose their lives as a result of not being able to get the treatment that they need to get in order to get healthy or to remain or to be healthy. So it is a huge concern of mine, but I am always hopeful. I am always hopeful that things will turn around. Things can be different, but it's something that the citizens in our community really we have to realize, we have to face it, and we have to advocate for it. We have to advocate. Sometimes things get to sometimes things can look so grim that we just give up and give in, and my hope and my prayer is that we will remain vigilant and 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 do what we need to do in order to take care of the folks in our city.
Yeah, thank you so much for that response. Dennis, I'll hand it over to you now.
Natalie, I just wanted to follow up. One of the things, Lynn, you and the mayor and the committees that you and the mayor put together have really tackled the problem of indifference. One of the things that we've learned since we started doing the racial healing and reconciliation conversations is that it's indifference oftentimes that causes people to have lack of access to their needs, to have their needs fulfilled. And the kind of statistics that you're sharing with the population through the prestige of the mayor's office, I think can have a long-term impact. When you're able to show that, gee, there was a time when things were more evenly distributed than there are now, makes you want to say, well, what did they do then that's not happening now? What's happening in society? But getting this out in the open, in front of everyone. You know, one example, for instance, this what I call the big ugly bill. Not only does it cut Medicaid, but it sets up barriers, very similar to the way certain states are setting up barriers to voting. So that if, for instance, if you don't renew your form that tells the state that you're employed, you could lose your Medicaid. A number of little tricks, cruel tricks like that, that I think just make it a big ugly bill. But these are the kind of things we have to stay vigilant about. And I agree with you, Lynn, that we have to be hopeful that as people see these problems and they see the impact, that they'll want to get out there and help those people who are in need. And again, I want to thank you for being with us this evening, and also thank our partnership with Pause for the Truth and our interns, particularly those you see before you tonight, who have been working hard for great town halls like this. And on behalf of the Urban League, I just wanted to thank you, Lynn, for being with us tonight.
Well, I appreciate you all asking, and I appreciate the time. Thank you.
And also a shout out to Sadia Barge, who is our intern coordinator and helped bring these great interns to the Urban League for the summer.
Great. They have been excellent.
Thank you. Thank you, everyone.
Thank you all.
Thank you.
Have a great evening, everyone.
Thank you.